All right. So we're now recording. So we have today we're doing chapter 37, Geriatric Emergencies. We're at the end. We're at the end, folks. So that's awesome. So like I said, this is a long chapter. It's also a high miss on the NREMT exam. So we want to be sure if we have any questions or if we need to foot stomp anything like that, then I'll try to find some of those as we go along. Okay. All right. All right. Awesome. All right. There's your National EMS Education Standard of Competencies. All right. So geriatrics is the assessment and treatment of disease and or injury in someone 65 or older. It says a decline in our body system start in our late 20s and progresses slowly throughout our lifespan. And trust me, I feel it. I feel it every day. I feel like there's a decline every day. But you'll start to notice things. You'll start to notice changes in your heart rate, your metabolism. You start to notice things about your blood pressure, your skin, your eyes, your smell, your taste, your senses in general. They start to weaken or they start to change as we start to get older. And it's a lot of it's just because of use of how we're using our bodies and what we put our bodies through. So older persons will continue to become a larger percentage of the population, right? And remember to treat every patient the way you would want your loved ones to be treated. So mainly what they're talking about in there, if you've ever had to deal with your advanced age patients, then you'll know that a lot of times they speak a little slower. They have a different viewpoint than you do. They may not hear you as well. Patience is going to be the key for working with these patients. And a lot of times they're polypharmacy, meaning that they have multiple medications that they use. You definitely need to make sure that you're writing those down. I understand that it can be a pain to write that whole list down. What I always do is if they don't have a list, a lot of your patients that are polypharmacy, keep a list or keep a notebook with a list on it or something to that effect of all of their medications. If they don't have one, I'm going to write it down that first time and make sure I check the dates of everything, how it's going, if it's even in a bottle. But what I'll do a lot of times is I advise them, hey, you should go to your pharmacy and have them do a print off or your caretaker to write down all the medications you have. That way, when we come back or if we have to come back, we can take all your medications and we can actually see how we need to care for you more efficiently. And so a lot of times, that patient education helps out tremendously. And you have to build a good rapport with those patients also. So speaking to them in a calm manner, being helpful with them and being patient is going to be a huge stride in the rapport sector. All right. So the economic impact of aging. Be aware of the economic impact of aging. We're talking about now they're on things like Social Security is going to be a primary source of their income, and there's not a lot there. So they're actually going to make decisions whether they're going to take medications or not take medications. And it sometimes that can be life-threatening decisions. So they may not seek care like they should because of concerns with cost or how expensive it's going to be. They may not want to take an ambulance ride because of the fact that they don't want to get charged for it. They don't want to have to pay for it. And a lot of times it's not so much, we say to them all the time, only pay $5 towards your bill every time. Only pay this much. Don't pay for it right now. Hold off on it. That's true. Whereas you can do those small bill percentages at a time, it still doesn't help because they know that once they leave this earth, the burden of those payments could possibly fall upon their families. And so it's more of an issue with them having issues of being a burden to their families once they're gone or while they're in care. And then also you see here that they may skip days on their dosages just to reduce the amount of medications that they're taking. And that can be very dangerous. So only a small percentage of older people live in nursing homes. And that's true. We see a lot of them as we're out and about, or we go to their homes and they're run down or what have you. So a lot of these patients don't get taken care of as well if they're not in the nursing homes. Family members may only be able to come see them and give care every now and then because of their own jobs, their own lives, and then also funding, or whatever type of monies that they're getting, they may not be able to afford to stay in nursing homes and such. So many of the patients are in the home where they grew up, and they may have a fear that if you take them to the hospital that they'll never see their home again. And you see that there. And that is very true. And I've actually had patients that have said that have that fear that you're going to take them away from their home, or that they'll never come back. They'll never make it back. Okay. And it says most healthy adults strive to live independently. Of course they do. All of us do. And they strive to live independently. And some of them think that they can live independently, even though we know that they should not probably live independently. So they may believe that they're able to care for themselves and handle activities of daily living, and they may not be able to. And there's times that we have to inform them of that, or we have to help firm up that advice that maybe family members have been giving or friends have been giving for a while, that they may need to seek for a caregiver or seek to go to a nursing home or what have you. So we may have to put that in their ear, because a lot of times they become 911 abusers, if not, and then they call, and it becomes an issue for the 911 system in itself. So some older patients do not have family or friends to assist them and are self-dependent. They're self-dependent because they have to be. They have to be. And it says isolated from the outside social events, are susceptible to self-abuse or alcohol or medication abuse. And that's very true. Unfortunately, it's the same process of thought as if you were left alone for long periods of time and you couldn't help yourself out. You get into a depressive state. Just because you're older doesn't mean that your frame of thought changes. Okay, you get forced into these situations sometimes. The stresses for the chronically ill can become very overwhelming, especially for the caregivers. If it's a family member that's a caregiver and they're living in their house, it can become very stressful because the daily life of the caregiver or that family member that they're staying with has a family as well, maybe, or has a life of their own that they're trying to balance as well. And then it can be a constant job making sure that you keep everything balanced. And so that creates problems in the home. And that's where you may run into issues with abuse or neglect in some of these homes. So mentally competent adults and emancipated minors have the right to consent to or decline treatment. Advanced directives, this is all chapter 1 stuff. Advanced directives may take the form of a do not resuscitate. And I always ask about those. If we go into these homes with these patients, I always ask whether they're in good health or not. I want to ensure that their affairs are in order, or that we're going to meet their wishes whenever we show up, or if we have to show back up. And the fact of the matter is that we may have to show back up to those homes in a not so great situation. So if you have to go to those houses and you know that those patients they're way advanced in age, we're dealing with our geriatric patients with a lot of these issues that they have. Wouldn't it make sense as part of our patient education to educate them on this as well? And we're not saying go get this. We're asking, do you have these items? Where are these items? Are they up to date if you do have them? We want to be sure to provide you with exactly what you're asking for if we have to show up for any of these situations above. So a DNR order, a DNR order gives you permission not to attempt resuscitation for a patient in cardiac arrest, but there are some things that you need to be aware of for it. Make sure it's within date. Make sure that the physician signed it. There's a list of things that we need to make sure is all together before we make those decisions. And in advanced directives, make sure that we read them and make sure that we're clear on what they want or what they don't want. If they don't want to be intubated, or if they don't want certain medications, if they only want palliative type care, which you're going to give that anyway, even if they have a DNR, you give palliative type care. But it can be really specific as to what they do and do not want. All right. So the physician orders for life-sustaining treatment is more expansive and encourages physicians to speak with patients with a terminal illness. They create specific orders to be followed at the end of life. Is pretty well what that's saying. You have healthcare proxy is going to be a named surrogate to make a decision for them regarding their healthcare in the event that they are incapacitated and unable to make decisions for themselves. And that's when you come in and you'll have a family member that's sitting over there saying, this is what's going to happen. This is what's going to happen. I am their healthcare proxy, blah, blah, blah. But if during your assessment, you know that patient is with it, if you know that patient is perfectly capable of making decisions on their own, then it's not that proxy's position just yet to make decisions. It's still in the hands of the patient. And I've been on scenes. Some of you may have been on scenes that you've witnessed that the family member, before the patient is even having any issues mentally, or they're perfectly with it, they're able to make decisions. Family members are trying to make decisions for them, and you have to tell them. You have to be like, hold on. I see here that they're able to make these decisions. I did my assessment, and this patient can make their own decisions. All right, so communication is the key to productive encounter with a patient. And this is what we talked about. Ask as many open questions as possible. So open questions meaning they can explain, and sometimes they will explain for quite a bit. Use close-ended questions to clarify points. So if you need to get that yes or no and just yes or no's, maybe for time efficiency or what have you, ask those close-ended questions, but make sure you're doing it in the right format. If you want them to explain things, you need to ask those open-ended questions. Avoid being overly familiar with the patient. And because you may miss things. These patients, we go to them on a constant basis. We have frequent flyers or what have you. If we become overly familiar, we get in there and then we assume we know exactly what's going on that day. And a lot of times we may not. And so we want to make sure that we're still doing our full justice in all of the full assessment and making sure that we're questioning our patient just like we would any other time. It's okay to be familiar, but being overly familiar can cause you to be complacent. Avoid being judgmental. You want to gain the patient's confidence. After interviewing the patient, ask family members or caregivers to clarify what you've learned. And you may encounter a geriatric couple that's been together for many years with no immediate family. And that does happen a lot of times. And leaving that one patient behind, that may be something that you have to see if you can see if you can coordinate if that patient could come with you, or is that patient staying behind, or is there going to be two patients, quite possibly, if anything happens. All right, so response to a nursing or skilled care facility. All right, so going into a nursing home, a lot of times you don't get a lot of answers. You may not get a lot of answers, or the ones that you're looking for. It's going to be the same assessment no matter what. Don't go off what somebody tells you just because they told you, if that makes sense. You need to do your own assessment. Listen to what they say. Listen to what they have to say. Take note of that and write down anything that they have, or make note of anything that they give to you, but then also do your own assessment. Okay. I know, especially now during COVID, we have different procedures. We had to be masked up. We had to sign in. I've had to go in and this patient be a full code, and we're going in CPR in progress. And I got stopped at the door so that I could answer the questions. Have you felt sick today? Is your feet? And then I had to get my temperature taken, and then I had to sign in and everything else. And you want to talk about aggravating at times. Be patient, go in there, because if you argue, you're not going to win. You're not going to win those arguments if you argue. Just get it done, go through, and get your job finished. I'll tell you this from experience. So infection control being a high priority, yes, most definitely. A lot of infections like MRSA happen a lot of times. Your nosocomial type infections can happen while at those nursing homes. So make sure that you're geared up for that. Make sure that you have the correct PPE on for those type of situations. Some of this stuff is very highly contagious. And so you want to make sure that you're protecting yourself and your family and everybody else in your department. Also, C. diff is another one. So it's a bacteria that's responsible. So what you see here, the Clostridium difficile is a bacterium, which is C. diff, is a bacterium responsible for the most common cause of hospital-acquired infectious diarrhea. It's bad stuff. And once you smell it and you recognize it as that, you'll never get that smell out. You'll know it every time. All right. So there are many leading causes of death. There are many causes of death. Heart disease followed by cancer, chronic low respiratory disease, stroke, Alzheimer's patients, diabetes, trauma, and pneumonia. Acute illness or trauma are more likely to involve organ systems beyond those that are initially involved. But a lot of times what you see is like your heart disease and your respiratory diseases are all what kind of you'll see those are the most prominent. All right, there's some factors that affect mortality in older patients there. So when we talk about the incontinence, the ability to hold urine and feces, they sit in those beds all day if they're not getting up and getting around. And at that point, they end up with ulcers, end up with ulcers on their back or decubitus ulcers. And those cause a lot of issues too, all the way up to sepsis, and cause issues with patients being septic because of some of these decubitus ulcers or some of these bed sores that they get as a result of being in those beds and not being clean as they should be. All right. So the aging process does not necessarily mean the patient will experience disease. It doesn't. So a lot of these patients do take care of themselves. Sorry, I'm trying to adjust my screen. A lot of these patients, they take care of themselves. As long as they take care of themselves, you're not going to see the same aging process across the board. You'll see different ones all across. It just all depends on what their state is or how they take care of themselves or how their family takes care of them. So as they age, they undergo a lot of important changes. There's a list of them there. So you start to ask, why does these things happen? Well, like blood pressure steadily increasing, that can be due to atherosclerosis, things like the hardening of the arteries, hardening of the veins. And you'll even see as you're doing IVs on these older patients, you may see their veins. You may see very good veins that are there, but a lot of them, they'll roll really easily. It's because they're hard, and it's because they're not held in place as well by the smooth muscle or the muscle that's for example, in the arms. The skin is really loose. The skin will also tear very easily. So you have to really develop that skill, that IV skill, when you're giving IVs to those patients. Also, bones can become weak. So doing CPR on these patients, it's very traumatic. The CPR may end up being what kills them in the long run, because of how easy it is to break bones, or how much bruising happens, or the trauma that can happen because of the CPR. That's some of the risk that we have to run, or that we take whenever we're performing some of those different treatments. So the respiratory capacity undergoes substantial reduction, and it talks about alveoli may become enlarged. It becomes enlarged, but they don't fill all the way. And then the elasticity decreases, and that's part of that enlargement. So the elasticity, loses, kind of like a pair of pants or a pair of underwear or a shirt. The elasticity of that shirt, the shirt will get bigger, or those pants, your favorite jogging shorts or your favorite boxers or whatever, will get bigger because the elasticity loses, but it never gets any smaller. So, and you don't feel it anymore, or some of us do, but it's the same way. It takes, and it loses that elasticity to be able to force that air out as well. So it doesn't fill it as much, and it can't force it out as well either. And you don't have as good of exchange because of that. All right. Can anybody explain to me what kyphosis is? What is kyphosis? Does anybody remember that from EMT? Yeah, your head is forward, you're hunched over a little bit. That's right. Your back hunches over. So if you do that on yourself and you try to breathe, it's a little more challenging, right? So it's the same thing that causes issues there. Because your muscles don't work as well, same thing with your esophagus. It doesn't work as well either. So you're more likely to choke on different types of foods or other types of secretions, just like a child at that point. So chronic lower respiratory disease and pneumonia remain the top causes of geriatric death, like we talked about, respiratory issues. Pulmonary embolism causes a sudden blockage of artery by a venous clot. We've talked about that in past sections about PEs and how to find a PE or what to look out for a PE. And so think of those symptoms, but it may not be as prevalent in your geriatric patients because their senses and their signs can actually be a little more deadened than in your younger adults or in your pediatrics. Cardiac output starts to decline. And then also with the electrical conduction, different things starting to die off, the myocardial tissue becoming older, becoming hardened. It's going to create electrical issues. And at that point, that's when you can have dysrhythmias that may begin to develop. We've talked about in past chapters about AAAs or abdominal aortic aneurysms. And so if the walls of the aorta start to weaken, whether it be from hardening or what have you, and something happens, either it gets a tear or a swell and pops, that can cause significant blood loss, internal blood loss, and you can actually bleed out from the inside and die pretty quickly from those. So a lot of times they'll have severe back pain, a burning sensation in their back that's severe, things like that. That some of the signs or some of the symptoms that you may hear. And because of the decrease in blood volume and decreased flow to the brain, the patient may experience types of syncope or syncopal episode, fainting. Excuse me. All right, so the aging produces changes in the nervous system that are reflected in the neurologic examination. So short-term memory impairment and slower reflex times are normal in the aging process. So don't think of every time you have some sort of issue there that it's automatically a stroke. Do your full exam before you start making these decisions. All right, so there's all sorts of vision impairment you see there. Glaucoma, macular degeneration, retinal detachment. It's another problem in older patients as well. Your hearing starts to change, or you can't hear high frequency sound anymore. Who's ever done the app or the YouTube? They have a YouTube video of different it's different frequencies and who can hear them. I know there's one that only dogs can hear. There's one that only kids can hear, and then so on and so forth. So that's kind of where that change is, and they work because I can set it off and I can't hear it at all, but my kid will be across the room holding his ears because it hurts so much. It's so loud, but I can't hear it at all just because it's at a frequency that's higher than what my ears has the ability to hear anymore. And you get this thing in your hunter's ear, the cilia that's in there, or cilia that's in there. as it starts to wear down, it affects those frequency responses. Other things that start to decline are going to be like your taste and touch. So many older patients may grasp your hand as a means for comfort, or during severe pain episodes. They may just hold your hand and hold it tightly. I know I've seen that a lot. So a lot of times just offering that hand helps out quite a bit. Smell starts to, I can't smell barely at all anymore. I don't know if that's age though. So you have a lot of disorders here. Delirium, which is a change in mental status that's marked by the inability to focus and think logically and maintain attention. Delirium may be caused by several conditions. You got to assess the patient for the following 4 conditions. So hypoxia, hypovolemia, hypothermia, and hypoglycemia are what you're going to be looking for. Your H's, 4 H's, right? So the most important thing to see here in the dementia as you're reading through it is dementia is not synonymous with delirium. Okay. So the slow onset, it's a slow onset or a progressive disorientation. It's not going to be synonymous with delirium. So it's a much slower onset. Neurodegenerative diseases such as Alzheimer's disease, the death of the neurons of the brain. We've talked about neurons before, what the neurons in your brain do. The neurons is what creates thought. It's what creates decision making. The neurons is how your brain works. When the neurons start to die, then those parts of your life start to go away. And that's what we call Alzheimer's. It's a gradual change. Symptoms of it could be confusion, personality changes, judgment, and difficulty with daily activities, things like that. There are a few tests that you can do. One being the clock test on those patients. You'll have a plate. You can take like a paper plate, or you can take a piece of paper and you draw a knot of that. I can't touch that. It doesn't allow it. Need all my screens to be touch screen. Well, where is my drawing on here? Nope. Well, I used to be able to draw on here. Now it's my annotation. It was annotate. That's what it was. And it's not on here anymore for whatever reason. That's odd. All right. Maybe I can do it through here. All right. So, like one of the things that if we're looking for any type of issue, That's a perfect circle. And so, generally we would, we ask them, hey, draw a clock. If you would draw a clock with one, or I'm sorry, I did it wrong. 12, 1, 2, 3, you get it all the way around, right? So what winds up happening is when they have some sort of issues, mental issues, is they start to draw this clock. And as they start to draw this clock, you may see something like this. Something like that. They only draw half the clock over. Or there's other things that you can do. You can take items on a plate, and they may only be able to pick out the items in this area or one side of the plate. Interesting. Drawing on the screen. Is anybody else seeing the drawings on the screen or not seeing the drawings? Not seeing the drawings? All right. Well, that was a pretty good activity there. Well, I don't know where my annotation went. Or annotate went. Sending me a picture of what the screen looks like. Oh my goodness. You know why? Why didn't y'all tell me? No, I'm not screen sharing. That's why I don't have annotate. I've been drawing on this and everything. It's the last class. It's the last class. If I can make it through this, I can make it through anything. Oh my goodness. Yep, not screen sharing. So, all right, now I'm screen sharing. Wow, what a clown. All right, so now I am screen sharing. That's going to make for an interesting recording, me just talking. Yeah, you've been needing that. That's crazy. All right, now can you see the screen? All right, great. Oh my goodness. Torrance, why didn't you tell me? A big picture of my goofy head up there. All right, so back at it. All right, so back at it. My apologies. I'm so sorry. So what I was talking about is that's a perfect circle. Okay. All right. So a lot of times, you would have, you tell your patient, hey, I want you to draw a clock face with the numbers on it. So you get the 12, 12, 1, 2, 3, 4, 5. You get the idea, right? So what happens is these patients that sometimes have these mental issues, or sometimes these Alzheimer issues as well, it's different types of neurodegenerative conditions. So what happens is as they start to draw this clock out, all of a sudden that it may look like that. They think it's in a perfect circle, or it may just be a series of, they think it's in a perfect circle, but it's not. So that's some things when you're looking for neurodegenerative conditions. My goodness. Or you may notice that on a plate of food that they're not eating things that are on one side of the plate, but they'll clean this side of the plate. Okay, you may notice that. And so it's just things to look out for. All right, 10 more minutes. I'll get a coffee, and maybe that'll help pep me up a little bit. Holy cow. I went through 36 slides with just my goofy bobbing head on the screen. All right, so Parkinson's disease involves the nerve cells in the motor area of the brain. May be present with dyskinesia, dementia, depression, autonomic dysfunction, and postural instability. Not postural instability meaning they can't sit up very well. You've seen the effects of Parkinson's disease. Michael J. Fox had Parkinson's, he had Parkinson's disease. Real shaky hands a lot of times, can't control it. All right, so as we can see here, depression and suicide. Depression is not a part of normal aging, but rather it's a medical disease. It's treatable just like with anybody else with medication and therapy. Depression can be extreme and persistent because they're alone with their thoughts a lot more of the time, or they're left alone, or people just they don't look into it. That's that crazy old man, what have you, whatever the opinion may be. Some other things too is that they look at that depression, and they look at those suicide, that thought of suicide in a different way. They're near the end anyway. They don't want to be that burden portion. I don't want to be a burden on my family. I don't want this to happen. I don't want that to happen. I'm done. I've lived a full life. I'm out. And we've had patients do that. I had a patient that was diagnosed with cancer. He treated the cancer for a long time, went into remission, became much older. And when he got much older, they found cancer again in his body. He didn't want to fight it. We got the call. He had went into his workshop in his shed, and he shot himself. We found him in his workshop. And we've seen that a lot of times. We've seen the different effects, the pills, overdose by pills and what have you, because of those situations, those type of situations. So musculoskeletal system, aging is associated with a widespread disease in bone mass in men and women. That's why it's important to make sure that you take care of yourself. Yes, Ty, it was. You remember that? Yeah, that was years ago. That was a long time ago. So cartilage goes through the degenerative changes with aging, contributing to arthritis. So it's just that aging process. And again, dependent upon how they take care of themselves, or what type of care that they have is going to contribute to the severity. So this is a picture of kyphosis like we're talking about. So flexion of the neck, anterior curling of the spine. That's kyphosis. And we like we talked about, that this creates issues with breathing. Osteoporosis, we have decrease in bone mass and bone density. Osteoarthritis, it's a progressive disease, causes bone spurs in the joints and results in bone stiffness. All right, let's take a, nope, I got 5 more minutes, sorry. So you also have GI issues. So you got a decrease in the number of taste buds and olfactory sensors. That's why sometimes they don't taste the food as well or smell it as well. So the taste is different. They may have bland, they may eat a lot of bland foods, or they may eat foods that are way off in taste that you wouldn't take or that you wouldn't want to eat or anything like that. And that can create issues because their body doesn't recognize that food that's too spicy or that food that's way too salty. Doesn't recognize, just eats it. They may eat rotten cereal or rotten milk in cereal, things like that, just because they can't do it or they can't sense it. Dental loss creates a lot of issues. Along with that dental loss, you have certain types of dental diseases that can happen. And as we all know, things that happen with your teeth can cause severe issues throughout the rest of the body. So bleeding that travels through the lower digestive tract.
COFFE. Cough.
That's close. You're mighty close.
Yeah.
Yep. Love you. Thank you. You made me coffee. And he left off an E when he was spelling it. So bleeding that travels through the lower digestive tract usually manifests as black or tarry stool. We've talked about that in past issues. And that's called melena. Do y'all remember that? Called melena or melena. So patients like that are more susceptible to get food poisoning because, like we said, they can't taste it the same way we do. They can't tell that it's rancid like we can sometimes, or they may not cook it all the way through. And then also their body doesn't break down the food or fight off the bacteria like ours does. And so you have issues with that. You can get salmonella poisoning, as you can see there. All right, and you got changes with the kidneys that can happen as well. As the body ages, the kidneys lose function in the nephron units. The aging kidney it's less able to excrete a large sodium load because of its lower glomerular or glomerular. We'll say glomerular filtration rate. So because of those aging effects, can't excrete that sodium. All right, older patients are more susceptible to hyperkalemia. We talked about that, what that can cause. It causes releases of myoglobin, things like that in the body, which can poison the heart, right? And that's that hyperkalemia that can turn into rhabdomyolysis. We've talked about skin breakdowns because of incontinence a little while ago. All right, let's go ahead and take a break there. Take a 10-minute, and then we'll come back. For some reason, there we go. Also, think about, I've gotten a couple of dates from a couple of y'all. I still need some more dates for from other students for your ride-alongs. I just need dates and where you plan to take them. Dates. I'm working it out with Rob where they need to go or how we need to move forward with it.
Google Career Certificates provide online training for in-demand jobs. Train for jobs in IT support, project management, data analytics, user experience design, and more. Put your skills to work.
All right, can y'all hear me now? Did I actually unmute myself? Okay, I'm gonna go ahead and keep going then. All right, so changes the endocrine system. You got the hormone levels and reproduction hormones that change as aging goes. Sorry. So the most common risk factor for the disease of the hypoglycemia is having more than one chronic disease. So that's the most common risk factor in there. See some more changes in endocrine system. More thyroid, and you see there thyroid abnormalities, which can also cause atrial fibrillation. Changes the immune system. Your immune system does start to get weaker. Sepsis can occur because of infection pretty quickly in the patient because of the toxic byproducts of whatever infection getting into the bloodstream. And then you see here the integumentary system or skin. Your collagen and your elastin decreases as you get older, and which we were talking about, you get that paper thin skin at that point. Healing can take a lot longer to do because the epidermal cells, they develop more slowly, and the replacement and everything, it doesn't happen as quickly. So they get that paper thin skin. It can cause rips, tears, anything like that. You have to be careful how you handle these patients. Whenever you're doing your treatments, you got to be a little more cognitive of these issues. Even tape can cause someone's skin to rip off. Because of the sebaceous glands, which causes naturally occurring oil, like the oil on your face or the oil on your skin. Because those use less oil, the skin gets drier, and that causes issues also. Pressure ulcers, we've talked about those, talking about the bed sores, decubitus ulcers, things like that. There's a start of a decubitus ulcer there in a patient. Lying in one position for too long. That's why, in the hospital, they want you to change every 2 hours. They change even if it's putting the pillow on one side or another, just to get a little different movement going. And as you can see, there are other changes with the aging, progressive loss of homeostasis or homeostatic capabilities occur. So your body's not able to maintain homeostasis like it used to. Now, there's no set way on how fast this happens. Like we talked about before, it depends on a multitude of reasons. Mostly due to how a patient gets taken care of or takes care of themselves coming up, or as they're getting older, as they're advancing in age. So kidneys undergo changes, and if the kidney undergoes changes, it causes causes issues with the body being able to filter toxins out of the body. Liver function, it's harder to detoxify the blood. You can see there polypharmacy, that causes issues with liver and kidneys. Polypharmacy being, multiple medications. If you suspect any type of medication non-compliance, you should check the prescription dates and the number of pills available. So make sure you know how to do those counts and pay attention to that. We're not going to do the assessments. We talked about that. We should definitely know how to do these. All right, so medical care. Interventions may include positioning, oxygenation, administration of glucose, and psychological support for some of these patients. Fluid resuscitation, these patients. So it can be pretty challenging, depending on what's going on with the patient. If they already have issues with oxygenation or proper perfusion. So if you dilute the blood and you're diluting it with something that is not oxygen carrying, such as your fluid resuscitation fluids, then you're going to have issues with that. And if you have issues with that, then that's going to cause sorry, my timer went off. All right, so if you have issues with already being able to oxygenate your body, the dilution of your blood is just going to cause more issues with being able to oxygenate or perfuse throughout your body, or be able to supply it with proper oxygenation. And so you can result in even worse hypoxia at that. So fluid resuscitation is a little tricky with these patients. And then a modest amount of fluid can quickly result in shock. Something to think about too. They're already having blood problems. And also their heart, your stroke volume's already down. There's going to be multiple issues with that as well. So it's already not functioning as well as it did whenever it was younger, their heart. And so now you're going to have issues with the blood, the pump in itself. And so hypovolemia can happen pretty quickly because those patients already have issues. Shortness of breath, a lot of times that's just that's a part of life, depending on what's going on with that patient. And then also you want to make sure the gathering of their medications. A lot of times they don't tolerate nasal cannulas very well. Or I'm sorry, they don't tolerate nominal breather mask very well. So nasal cannulas is the way to go with these patients. And a lot of times you'll have issues with CPAPs as well with these patients, trying to get them to breathe through a CPAP. You just got to ensure them that it is helping them. It is going to keep them oxygenated. So again, we were talking about, making sure that you study up on your alpha and betas. There's a beta adrenergic agents, and that such as what's in your asthma medications, and it can cause further cardiac issues. So you want to make sure that you're not doing something that's contraindicated to what's possibly going on. Pneumonia. So a lot of pneumonia, CPAP. CPAP is definitely the way to go. Listen to those breath sounds, auscultate. You're listening for those crackles, right? Wheezing, crackles, rhonchi, things like that. You want to make sure that CPAP, give them their patient education, put them on that CPAP. It helps out quite a bit. You want to keep the patient warm without overheating. So check for pulmonary embolism, check for that swelling, the erythema, and warmth or tenderness in the lower legs. That could be because of a DVT, right? So we talked about syncopal episodes, different things can happen in those patients. And whereas a younger patient, a syncopal episode may not be that serious, in an older patient, it could be life-threatening until we prove it otherwise. So something in their body has caused a temporary interruption of blood flow to the brain. We need to find out what it could be. And there's a list of stuff that it could be a causes and mechanism. It should be in your book too, chapter 37, and it'll be table 3, so 37-3. They're yelling at my dog in there. Again, assessments, we ran over assessments whenever we did our boot camp last. It's going to be the same thing, same type of assessments. Okay. The same issues, just may be a little bit different because of their age. The assessment, though, is still going to be the same. If we find abnormalities, then we make notes of it, or we find if we have a treatment for it, we give a treatment for it. Pathophysiology of trauma, we've talked about that. What can be called or what can cause that, as far as what changes with geriatric patients. They react a different way. Hypovolemia can be a big deal pretty quickly for those patients. Respiratory issues that are already in play could be issues there. Hypothermia is something that happens a lot of times with these patients because they've lost a lot of their ability to thermoregulate. So we want to make sure that we treat for that shock. Now, elder abuse, this is now abuse and neglect. So a lot of things we can see here. See the financial there, the embezzlement, being family members taking their check, their Social Security check, cashing it and spending it, or any money that they have coming into them, cashing it and spending it. It's a lot of issue that happens there. And that can cause even further depression because they know what's going on. They just can't stop it. And a lot of times, you'll see these patients with bumps and bruises, kind of like in your pediatrics. But whenever you see abnormalities in those bumps and bruises that happen, they shouldn't happen as much in an older patient because an older patient usually has experience. They don't move around as much as a child does. So we want to make sure that we're paying special attention to any of those bumps, bruises, broken bones. And broken bones may take a long time to heal, if they ever heal, depending on how old the patient is or how frail the patient is. So the physical and emotional signs. So just like in your child abuse patients, they may be dissociative. So that may be something you're looking for. So oval grab marks, pinch marks, handprints, things like that we're seeing here, just like in your PEDS patients. And bites in the upper extremities. This can also happen in your nursing home facilities where patients are doing it to each other. Okay. So it's not so much the nursing staff causing abuse, but another patient, and it's not being reported properly, or those patients aren't being separated properly. We need to be able to recognize things like that. So patient weight, making sure that we're seeing if those patients are being treated or are being malnourished, or if they have malnourished problems, nourishment type problems, undernourished. And also things like genitals and rectum for sexual abuse in those patients. We've had patients so bad before that, you know, we had to, when I was working in the hospital in San Antonio, we had patients so bad that we had to install an FMS system, or a fecal management system. And what we had to do is take a tube that's about that big around as it is, and it's got a bulb on the end of it, and fold the bulb up and insert it into the rectum, just so they wouldn't use the restroom on themselves, because their sphincter would not close enough to be able to handle it. It was actually turned in as possible sexual, you know, as a sexual attack that happened. And this patient never recovered from that, ended up getting very sick because of the infections and things like that happened afterwards. For your elder assessment, manage of elder abuse. So suspect abuse when answers to questions about what caused the injury are concealed or avoided. They don't answer you. They stare off. They try to change the subject. Anything like that, you want to do that. You may, if you have to get them alone, like in the ambulance before they start talking, you may have to do that. Same as like what you may have in a pediatric or an abused adult. You may have to take the same type of actions to be able to get some of that information. And if you suspect it, then you should say something. If the caregiver is apathetic to the patient's condition, just don't care. You know, they act the way they do. I've been in patients' houses where the caregiver or the family member put them in an RV out back and just had them in the RV and staying in that RV, and would rarely come over. Walked into the RV is a mess. There's stuff everywhere, bugs everywhere, and everything else. And that's what they put her mother. That's what they put her mother into, is this RV, and just kind of forgot about her from there. And then whenever we showed up, she made complaints that, did she call y'all? So on and so forth, made a raised Cain about it. And then sat there and cursed this lady the entire time we're trying to put her onto the stretcher. Cursed her the whole time. And finally, you know, we turned it in, and she ended up getting in quite a bit of trouble for neglect, abuse and neglect, and endangerment as well, because there were like heaters in there that were balanced on top of junk that was in there, what have you. There was a heater in there that was balanced on. If it falls over, catches on fire, that's it. That patient will never get out. All right, and there's some more things to look out for. All right, so a repeated abuse can put them at a higher risk of death, and that's because they can't heal. They can't heal properly, and so that creates other issues, and it can create a systemic issue in their body. And if they want to refuse transport, see if they'll accept help from APS or Adult Protective Services. If you need to remain there until law enforcement show up, then do so. Let your ambulance company know that you're going to be there until they show up. It's not your responsibility to prove that the abuse occurred, only to report the findings. Remember that. Make sure your documentation is tight with these patients, okay? Right. All right, so that is the last. That's the last slide there. For that. So our code tonight is going to be 7766. That's 7766 is going to be our code tonight. And there's not a code on the test. It's open, or it'll be open at 10 o'clock. So it's a 15 question test. Like I said, it's got a lot of it's, or the majority of it's going to be, or it's all going to be geriatric patients. I tried to keep everything peds, everything geriatric, no mixing or anything like that. I was talking about earlier, your final exam coming up. It's going to be, we're going to have a lot of questions on it, and you'll have ample time to take it. This is our last class. So there'll be no more classes after this. We are going to have the last boot camp. Talking to Rob, we were talking about it earlier. Rob's going to be on military status. I'm going to be on military status when it's supposed to be. I don't know how that schedule got brought up. I turned it in, but neither here nor there. So what it's going to look like we're going to have to do, and I just want to jump on this as early as possible, is that we're going to have to change the boot camp to the 13th and the 14th of November. I will be there on the 13th. Won't be there on the 14th because I'll be on duty on the 14th. I already know that. So we're looking at the 13th and 14th of November. I'll have to talk to Rob and see if they're going to do a 2-day and see if that's going to be something that we're doing. Okay. All right. But like I said, there'll be a final exam, and a final exam that's going to cover the entire spectrum. I'm telling you right now, most of the final exam is going to be scenario based. Most of the final exam. It's going to be, it'll probably be somewhere in between the range of 100 to 150 questions on a short time span, just to get you ready for Dnr EMT, to knock it out. Okay. All right. All right. So like I said, the code is 7766. I'm going to stop recording.